You're typing an email and then suddenly your hand goes numb. You're driving to work and then your fingers start to tingle. What's actually going on? If your hands are going numb, tingling, or you're waking up at night with pins and needles or pain, this video's for you. I'm Dr. Sam, a board-certified reconstructive surgeon. And in the next 15 minutes, I'm going to explain exactly what's happening inside your hand, why it's happening, and the surgery I performed to fix it. And at the end, I'll tell you the single most important warning sign that means you need to stop waiting and see your doctor immediately. Let's start with the anatomy, because you can't understand the carpal tunnel until you understand what the carpal tunnel actually is. The carpal tunnel is exactly what it sounds like, a tunnel. It's a narrow passageway on the palm side of your wrist, or the volar surface, about the width of your thumb. The floor and walls are made of bones called the carpal bones, which make up the wrist. The roof is a thick band of tissue called the transverse retinaculum, or transverse carpal ligament. Passing through this tunnel are 10 critical structures, 9 tendons that let you flex your fingers and wrist, and 1 nerve, the median nerve. That's the star of today's video. It's the reason your hand goes numb. The median nerve controls sensation in the thumb, index, middle, and half of your ring finger. It also controls some of the muscles at the base of your thumb, the muscles that let you pinch and grip. So when this nerve gets compressed, you lose feeling in those specific fingers and you lose strength in your thumb and grip. Now here's what the carpal tunnel syndrome actually is. When the tissues inside the tunnel swell, usually the tendons or the tendon sheaths, there's nowhere for that swelling to go. The tunnel is enclosed on all sides, bones and then the ligament, so the pressure builds up and the softest structure gets squeezed. That's the poor median nerve. Early on, the nerve just gets irritated a little bit. You feel some tingling, pins and needles, maybe some mild numbness that comes and goes intermittently. But if the compression continues, the nerve starts to lose function. Numbness becomes constant and sometimes even pain. Then you start dropping things as you can't grip or hold. The muscles at the base of your thumb start to shrink. And eventually, if left untreated long enough, the nerve damage becomes permanent. About 3 to 6% of American adults have carpal tunnel syndrome right now. That's roughly 10 to 20 million people. And it's the most common condition I treat as a reconstructive hand surgeon. So now you know what the carpal tunnel is. Here's the question: why does it happen to some people and not others? I'm going to walk you through the 7 biggest risk factors, and some of them are going to surprise you. Risk factor number 1, repetitive hand use. This is the one everyone knows about, but there's a nuance most people miss. It's not the typing itself that causes carpal tunnel, it's the repetitive strain on the tendons that pass through your wrist. Every time you flex your fingers, those 9 tendons slide through the tunnel, and do that 1,000 times a day, day after day after day, and the tendon and the sheaths covering them start to swell. Risk factor number 2, pregnancy. If you're pregnant or you recently had a baby and your hands are going numb, this is why. During pregnancy, your body retains significantly more fluid, and that fluid can build up in the tissues around the wrist, increasing the pressure inside the carpal tunnel. Up to half of pregnant women experience some carpal tunnel symptoms, especially in the 3rd trimester. The good news for most women, these symptoms resolve on their own within a few months of giving birth, as the fluid balance and shifts normalize. But if the symptoms do persist beyond that, it's worth getting evaluated. Risk factor number 3, diabetes. And this is the one that a lot of patients don't realize is connected. People with diabetes are significantly more likely to develop carpal tunnel syndrome. High blood sugar over time causes chronic low inflammation throughout the body, including the tissues around your nerves and in the carpal tunnel. It also damages the nerves directly due to that elevated and constant sugar, a condition called diabetic neuropathy. If you have diabetes and you're developing hand numbness, it can sometimes be hard to tell if it's carpal tunnel syndrome, neuropathy, or both. This is where a specialized test called a nerve conduction study becomes really valuable, and I'll explain what it is in a minute. Risk factor number 4, thyroid disease, specifically hypothyroidism. An underactive thyroid slows your entire body's metabolism, which can cause a specific type of tissue swelling called myxedema. That swelling affects tissues in your entire body, but specifically in the wrist because it's a confined space. If you're a woman over 40, developing carpal tunnel symptoms, especially associated with fatigue, weight gain, feeling cold all the time, maybe you should be getting your thyroid checked. And risk factor number 5, maybe you were just born with a smaller carpal tunnel. Some people are born with anatomically smaller carpal tunnels. There's less room for the nerves to begin with, so even minor swelling causes symptoms much more quickly. This is why carpal tunnel tends to run in families, why women develop it about 3 times more often than men. Anatomically, women tend to have smaller wrists and narrower tunnels on average. Risk factor number 6, previous wrist injury. If you've broken your wrist, sprained it badly, or had significant trauma to the area, scar tissue can form inside and around the carpal tunnel. That scar tissue takes up space that the nerve needs. Even injuries from years ago can catch up with you eventually. Risk factor number 7, and this is the one that catches most patients off guard, your sleep position. Most people sleep with their wrists bent, either curled under a pillow, tucked under their body, or flexed at extreme angles. When your wrist is bent for hours at a time, the pressure builds inside the carpal tunnel. That pressure increases dramatically, and that's why carpal tunnel symptoms wake people up at night with numbness, tingling, and sometimes even pain. So now you know why it's happening. Let's talk about what to actually do about it. Not everyone with carpal tunnel symptoms needs surgery. In fact, most people don't, at least not right away. Treatment usually starts with conservative measures and escalates if symptoms don't improve. First step, nighttime wrist splints. They're simple, they're cheap, and they're often effective for early stage carpal tunnel. You can buy them at any pharmacy, and the goal is to keep your wrist in the neutral position all night long so that nerve isn't being squeezed or compressed while you sleep. This is the carpal tunnel position. Just make sure you get the right wrist splint. Some don't do the full job. You want a nice angle here that opens up the carpal tunnel and lets it sit relaxed. Second, ergonomic changes. If your job involves a lot of typing, an ergonomic keyboard, proper wrist rest, and taking regular breaks can make a real difference. Third, physical therapy. Specific exercises called nerve glides can help mobilize the median nerve and reduce inflammation in the surrounding tissues. A hand therapist can teach you the right techniques. Steroid injections. If splints and physical therapy aren't working, a simple steroid injection directly into the carpal tunnel can reduce inflammation and provide significant relief. The relief isn't always permanent, but it can buy you months of comfort and then sometimes resolve the symptoms entirely. One other thing that we do for patients when we see them before going to surgery is a prescription for meloxicam, which is a once daily non-steroidal anti-inflammatory like ibuprofen. We typically give it for a 30-day period along with the wrist splints and have them come back in a month. If it's early enough, the anti-inflammatory medication along with the wrist splint and ergonomic changes can hopefully improve symptoms to the point they don't need surgery anymore. However, if they continue to still have symptoms, then we send them for specific studies, including a nerve conduction study and/or an EMG at a neurologist's office. That tells us the effect of damage that's already been done to the nerves. And then at that point, we can proceed with surgery. Those are the things that are required for most insurance companies to authorize the procedure. And then we can talk about the surgical technique. Now, let's talk about the surgery itself. This is called the carpal tunnel release, and it's one of the most common and most successful hand surgeries performed. Over 500,000 of these procedures are performed every year, with success rates about 90% or higher. Here's exactly what happens. ligaments. The surgery has one primary goal: release the pressure on the median nerve by cutting and releasing that transverse carpal ligament, or the flexor retinaculum. That's the thick band of tissue that forms the roof of the carpal tunnel. Once we cut it, the tunnel opens up, pressure decreases, and the nerve has room to relax and recover. There are two primary ways to do this procedure. There's an open approach, or open carpal tunnel release. This is the traditional technique. It's made with an open incision over the transverse retinaculum, and then you go in and cut the ligament under direct visualization. It's straightforward, reliable, and has good long-term results. The alternative technique is an endoscopic carpal tunnel release, where we use a camera. We make a small 1 centimeter incision at the base of the wrist, and we pass a camera inside. With visualization from the camera, there's a knife blade that comes up, it goes in, it hooks up, and then we cut that ligament. This allows for a quicker recovery, less downtime due to the smaller incision. The lack of the open incision also heals faster. There's less risk of the wound opening up and having healing complications. Both techniques can usually be done under local anesthesia. You can walk in, we do the procedure, and you walk out the same day. Immediately after surgery, your hand is bandaged. We place patients in a soft splint so they can protect it. Most patients experience significant relief from the nighttime numbness and pain, sometimes even immediately after surgery. The nerve was being strangulated and now it's not. So this is a dramatic functional and anatomical change. So here's the honest recovery time. Week 1, you'll have a bandage and your hand is wrapped up. You can use your fingers for light activities, but no gripping or heavy use. Some soreness at the incision site that's usually very well tolerated with some pain medicine. And then weeks 2 through 4, stitches dissolve so there's no removal necessary, and you gradually start to return to activities. We tell most patients for the first 4 to 6 weeks to take it very easy, no lifting over 5 pounds, and then if needed after the second week, we can have them start physical therapy and start to regain full grip strength and function. After about 2 to 3 months, any residual numbness or tingling typically continues to fade away, all the way out to about a year. You return to full activity, including sports and heavy lifting, after 6 to 8 weeks. Full recovery, including complete return of grip and pinch strength and resolution of all symptoms, usually takes 3 to 6 months. The promise I made at the beginning, the single most important warning sign that means you need to stop waiting and see a hand surgeon immediately. It's called thenar muscle wasting. These muscles will start to shrink, and that means that they're losing the nerve signal from that median nerve. The area used to be full and round, it starts to become flat and even sunken in. This means the median nerve is being compressed, and it's been going for a prolonged period of time, so much that the muscle it controls are starting to atrophy. Here's what I want you to leave with. Carpal tunnel syndrome is one of the most treatable conditions in medicine, but it's also one of the most undertreated. Too many people push through the symptoms, hoping it will go away on its own until they've lost strength and feeling they can't fully get back. Don't be that patient. If your hands are going numb, you're waking up in the middle of the night with numbness, tingling, or pain, get it looked at. The earlier you catch it, the better the outcome. If this video helped you, hit subscribe. I'm Dr. Sam. Take care of yourself and your hands.